Bismillahirrahmanirrahim. Dear students, in this class we will be discussing the drugs that are affecting or that are inhibiting the peptic ulcer. So by the end of this lecture, you will be able to recognize the main causes, complication, risk factors, and symptoms of peptic ulcer. Along with that, we will be able to define the classification of drugs involved in the treatment of peptic ulcer disease, their pharmacokinetics, pharmacodynamics, their mechanisms, along with that therapeutic indications and the triple therapy and quadruple therapy for the eradication of H. pylori, which is also one of the main cause uh, for the peptic ulcer. So to start with the definition, peptic ulcer disease is a mucosal lesion of the stomach or duodenum. The term peptic ulcer is used to describe both the gastric and duodenal ulcer. So it can be used for gastric or duodenal ulcer. And what is ulcer? When the mucosal layer has been damaged. Basically, this mucosal layer is providing protection against the pepsins and acid that is produced within the stomach. So whenever there is a damage occurs to this epithelial layer, then it causes the formation of ulcer. It causes the eradication or erosions of that arteries or layers of the internal walls of the stomach, and that can lead to pain and inflammation within this stomach. So the purpose of this drug therapy is to decreases the acid and pepsin production within this stomach in order to heal this peptic ulcer, in order to heal this epithelial layers. And that's why when peptic ulcer disease results when gastric mucosal defense becomes impaired and no longer protect the epithelium from the effect of acid and pepsin, which is secreted by the gastric parietal cells in order to detoxify or digest the food that is coming into the stomach. So in this lecture, we will be discussing all those drugs which causes the inhibition of acids and pepsins so that the epithelial layers can be regenerated in order to protect this layers of the stomach wall. Now where this acid is secreted into the stomach, this is basically secreted from the parietal cells, which are located on the walls of the midsection of oxyntic gland. So here these parietal cells provide proton, hydrogen, and then that proton is combined with the chlorine of the chloride within the stomach, and they causes the formation of HCl, a strong acid. Now where this how this parietal cell is activated to release the proton for the production of HCl. So we have to stop the process which basically initiate the production of proton, or which can increases the release of proton from this parietal cells. So how these parietal cells are activated? One of the factor is the food. Whenever the food enters into the stomach or into the into the stomach, that causes the activation of gastrin. So gastrin is a hormone that is secreted into the blood, and then it goes to the parietal cells and also to the enterochromaffin like cells. So what they do here, they causes the activation of gastrin receptors. Basically this in parietal cells contain 3 receptors for the activation of this pump that is called the hydrogen potassium pump. So one of them is the gastrin receptors, H2 receptor or histamine 2 receptors, and muscarinic receptors. Remember, you might have this you might recall from your autonomic pharmacology, sympathetic and parasympathetic system. So parasympathetic system that we have discussed is a rest and digest system. That means it causes the increase in digestion of the food, and for the digestion of the food we need this pepsin and hydrogen or HCl. So parasympathetic system causes the increasing in the release of these what we can say pepsins and HCl. So what we have to do, we have to stop this parasympathetic nervous system, and the receptor for the parasympathetic nervous systems are muscarinic receptors. So come again, we have food that causes the production of gastrin. Gastrin is a hormone that is secreted into the blood, and through the blood it reaches to the enterochromaffin-like receptors. So they are activated the enterochromaffin-like receptors and also activated the gastrin receptors on the parietal cells. So both of them causes the increased release of hydrogen from the parietal cells, or the proton from the parietal cells. Okay, now this gastrin, on one hand, it activates the enterochromaffin-like receptor to increase more histamine, and more histamine will cause the activation of this H2 receptors. So this is the paracrine pathway. This is the endocrine pathway, which is causing the release of new hormones from the gastrin gland, and that then moves through the blood and reach here to the enterochromaffin-like receptors, and then reaches the parietal cells to activate the parietal cells. This is the paracrine pathway. These enterochromaffin-like receptors are located near the parietal cells. That's why they are called paracrine pathway. So this histamine is directly released from the from this ECL cells and causes the activation of this H2 receptors, and H2 then further activate this proton pump. And then the third pathway is the neuronal pathway, that is coming from the parasympathetic nervous system muscarinic receptor. So there are three pathways for the activation of this hydrogen pump, which causes the release of proton into the stomach, and then causes the formation of HCl within the stomach. So we have to stop this. In order to inhibit the release of proton or HCl into the stomach, we have to stop all these three pathways. We have to stop this endocrine pathway, we have to stop this paracrine pathway, and we have to stop this neurocrine pathway, right? So here we can have gastrin antagonist, but here the drugs available, we have this H2 receptor antagonist, we have muscarinic antagonist, muscarinic receptor antagonist, and the third type of drug that is very potent, we can directly block these receptors here, proton pump. So they are the most potent. They're called proton pump inhibitor. They are directly inhibiting this pump. So in this lecture series, or in this chapter, we will be discussing all these three types of drug that is causing the release of proton into the stomach. So the gastric physiology, that we have acid secretion, there are three primary pathways that stimulate the gastric acid secretions that we have discussed in the previous slide. So the neurocrine pathway, which transmit the acetylcholines from the parasympathetic nervous system. Right, the endocrine pathway, which releases the hormones, that is the gastrin. So gastrin, this is the gastrin, they are increasing, or they are causing the release of gastrin, and gastrin comes to the parietal cells through the blood. While the paracrine pathway, which releases histamine, so this ECL, this is a paracrine, they are located adjacent to the parietal cells, and all these pathways causing the release of proton or HCl into the stomach. So this is a simple diagram which is showing the regulation of gastric acid secretions, how the acids are secreted into the stomach. So the gastrin that we have discussed, the endocrine pathway, that's gastrins come and activate the gastrin receptors and causes the activation of this proton pump. Then the histamine, here we'll have to know that the receptors here are H2 receptors, so it is different from the receptor that are located on the that are activated during the inflammations or during the allergic response. So basically they causes the vasoconstriction, the bronchoconstriction. So the bronchoconstriction, the receptors located on the bronchioles are H1 receptors, and they causes the contractions of the bronchioles. So it's different from them. H1 receptor antagonist or agonist that causes the contraction of the bronchioles associated with the hypersensitivity reactions, but here the receptor presence are H2 receptor, and H2 receptor, histamine 2 receptor, causes the activation of this proton pump. Acetylcholine coming from the parasympathetic nervous system, so it causes the activation of muscarinic receptors present on here on the parietal cells and causes the release of HCl into the stomach. So we will be discussing here these three types of. Okay, another mechanisms are very important to know here, the effect of prostaglandins E2. Remember, if you recall from the NSAIDs, we have discussed the one of the main side effects of NSAID is the production of ulcer. And why ulcer? Because NSAIDs are inhibiting the prostaglandins E2, which causes or which have a protective response against the ulcer. Because what you do, gastric, this prostaglandins E2, they inhibit, here they are activating the G inhibitory proteins here, and they inhibit the activation of this proton pump, right? So they are protective, they inhibit the release of HCl into the stomach. That's why when NSAID block this prostaglandins E2, that leads to the ulcer, because this inhibit the gastrointestinal production by increasing the HCl. So here we can have prostaglandins E2 agonist or analog, which will inhibit, which will activate this prostaglandin receptor. So if you activate this prostaglandins E2 receptor here, it will inhibit the release of hydrogen or proton from this proton pump and will inhibit the release of HCl into the stomach. Okay, now pathogenesis of the peptic ulcer. What are the factors that leads to this peptic ulcer? So in our body we have a defensive factors and some are aggressive factors. So normally they are in balance. Whenever these defensive and aggressive factors are in balance, then our stomach remains normal. So whenever there is an imbalance between these aggressive factors and defensive factors, then that leads to the ulcer formation. So aggressive factors, acids, pepsins, H. pylori, and NSAIDs, they can cause the ulcer formation, while prostaglandins, mucosal gel layers, and bicarbonate or bases, right? So they causes the defensive factor, they causes the decrease in the release of HCl. So whenever there is a balance between the acids and pepsins, prostaglandins, and this bicarbonate, then our stomach remains normal. But if the aggressive factors is increased or the defensive factors is decreased down, then what will happen? That will lead to the ulcer formation. If you have more acids or more pepsins, then it can lead to ulcer of H. pylori. We will discuss this. This is a bacteria that is one of the main cause of the H. pylori, is a main cause of ulcer. And NSAID that we have discussed in the NSAID, because they decreases the production of prostaglandins. So they inhibit the prostaglandin NSAIDs. That's why it can cause the ulcer. and prostaglandins have a defensive factors. Mucosal gel layers, this gel layer that is on the upper side of the wall of the stomach, that causes protection to the acids, and bicarbonate decreases the acidity of the stomach and decreases the formation of peptic ulcer. Back diffusion of acids. So if you can see, acids, bile salts, aspirin, NSAID, alcohol, all alcohol, ischemia, or H. pylori, all these factor causes the breakdown of the gastric mucosal barrier. So this gastric mucosal barrier is providing protection to the gastric wall against the acids and pepsins that are secreted into the stomach. So if that barrier is disturbed or break down, what will happen? The acid will diffuse back into the mucosa. That acid that is secreted, it will diffuses back into the mucosal layer, and it will cause the further destruction of the mucosal cells. And that destruction, it will also cause the release of histamines, and that further destructions will and so if there is more histamines and more destruction of the mucosal cells, so it will increase more acids and pepsin release. So more acids and more pepsin will further break down this mucosal layer and will increases the ulcer. So and then this further mucosal erosion, destruction of the blood cells, and bleeding. So that will lead to destruction of the blood cells, and that will also leads to the bleeding within the stomach, and that will lead to ulceration, ulcer formation. Histamine will also cause the vasodilation or increase capillary permeability. So that will lead to loss of plasma protein into the gastric lumen and will lead to mucosal edema. Right, so like causes of inflammation will be, or inflammation will also be there because of the histamine. So in order to stop that, we have to decreases the acids and pepsin release into the stomach, so that the mucosal layer is then, or the mucosal barrier is regenerated and protect the internal walls of the stomach. Complications, so what will happen? Hemorrhage, bleeding, right? So in turn, that bleeding, blood vessels damage as ulcer erodes into the muscles of the stomach or duodenal walls. So that will lead to coffee ground vomit or occult blood in tarry stools, or this also called melena. Because of this bleeding, the vomit will become like coffee types or coffee ground color. Also the stool will become a tarry blackish type, so that is because of the bleeding within the GIT. Perforation, in extreme cases, what will happen is that the entire wall of the stomach will be eroded, right? And the bacteria and food will then be go through the entire wall, and the food will spill into the peritoneum, and that will lead to peritonitis. So this is the extreme case of the ulcer, when the entire wall of the stomach is eroded, and the ulcer erode the entire wall of the stomach, and then bacteria and the partially digested food spill into the peritoneum, the internal cavity of the stomach, right? The internal cavity of the abdomen. Okay, nerving and obstruction. So it can cause the nerving down and causes the obstruction, pyloric obstruction, and then swelling and scarring can cause the obstruction of food leaving the stomach. So it will lead to repeated vomiting. So if the pyloric sphincter is narrowed down and obstructed, then the food will not be able to go down into the small intestine and large intestine. So that will lead to repeated vomiting. Risk factors, lifestyle. So smoking, that would be smoking, alcohol, medication like NSAIDs or coffee. It also stimulates the hydrochloric acid production. All these can lead to the damage of the mucosal layer. So that is the risk factor for the ulcer. H. pylori, this bacteria, it is 90% have this bacteria. Not basically, it remains dormant within the stomach, but especially in 90% of the patients do have H. pylori, but they does not develop ulcer. But in 10% of the patients, this H. pylori can leads to ulceration. So it passes from person to person, fecal oral route, or oral to oral route. So it can pass from one person to one person through different routes. Age, gender, genetic factor all contributed to the risk factor. Like duodenal is more common in person who have age between 30 and 50. Gastric is more common in older peoples more than 60 years of age. Genetic more likely if the family member has a history. Diseases like Zollinger-Ellison syndrome, this is a tumor like gastrinoma that secrete more gastrin. So if there is increased amount of gastrin, that will increases the release of peptic, the release of hydrogen or proton into the stomach, and will cause more production of HCl. Other factors like stress can worsen, but not the cause of the stomach. But all these factors can lead to the ulcer formation. The symptoms include the burning, epigastric pain, pain relieved with food and antacids, or nausea, vomiting, anorexia, and weight loss, nocturnal pain that awakens at the night or between meals, right? So this epigastric pain, because of the increased release of acid and there is no protection on the wall, so that leads to this pain and burning effect, and that is relieved with the food, because whenever you are taking the food, so for sometimes that ulcer is covered with the food or antacids. If you are taking antacid, that will neutralize the acid, so neutralization of the acid will decreases the pain. Nausea, vomiting, that we have anorexia, loss of hunger, and weight loss because of the less taking amount of less food and less digestion of the food. Nocturnal pain, this is important because during night time, this nocturnal is a nighttime pain that awakes in night and between the meal, because when you are not taking the food for longer times or during the night time, this excretion is more, this peptic secretion is more, HCl secretion is more, so that would lead to pain during the night times or during the between the meals, when you have long duration of action or long duration within the two meals. So emptying the stomach will leads to pain formation. Aim of ulcer treatment, so promotion. What we have to do, we have to promote the ulcer healing. And how we can promote the ulcer heal? In order to decrease the peptic acid secretion. Symptomatic relief of the pain, we have to decrease the pain, so we can give them symptomatic treatment. Prevention of recurrence, right? In order to inhibit the relapse, we can treat the H. pylori if this is the cause, and prevention of complication that is associated with this ulcer. Major causes of peptic ulcer disease, we have discussed infections with gram-negative H. pylori, that is one of the reasons. Increased HCl secretions. The parietal cells secretes proton in response to gastrin, cholinergic, and histamine stimulation, which stimulate the proton and potassium ATPase pump. Inadequate mucosal defense against the gastric acid. That what we have already discussed. So how we can manage this? We can manage this by increasing the defensive factors and decreasing the aggressive factors. And remember, the aggressive factor, the pepsins, the pepsin release or the HCl release. So how we can decrease this HCl release? By blocking this H2 receptors, by blocking this proton pump, and we can have muscarinic receptor antagonist, or we can take antacids or antacids which neutralizes the acids that is produced within this HCl. While the protective agents are the prostaglandin analogs. This is a protective agent because activating this prostaglandins receptors activate the G inhibitory receptors and the G inhibitory proteins, and then they decreases the cyclic AMP. So basically it is decreasing the activation of this potassium hydrogen ATPase pump. And we will discuss this sucralfate we will cause protection or form a gel around the ulcer at the site of ulcer and protect the walls of the stomach. And eradication of H. pylori agents to prevent the relapse or recurrence, because H. pylori is one of the cause for this ulcer formation. So for this purpose, in order to treat or in order to inhibit this H. pylori, we will need antibiotics. So in combination with proton pump inhibitor, we can use antibiotics in order to eradicate this bacteria H. pylori, which is one of the cause for ulcer. Others like cessation of NSAIDs, we have to stop this NSAIDs drug if that is the cause, or endoscopic or surgical treatment can be also be one of the options for the management of complicated ulcer, which cannot be treated with the medications. So the first drug in this class is the antacids, right, such as aluminum hydroxide and magnesium hydroxide. So what they basically do, they are bases. So whenever we are taking it, it will neutralize the excessive acid and will produce a prompt relief from hyperacidity. So these are normally bases, and they will react with the acids HCl and will neutralize the acid. So that is normally giving a prompt relief. So antacid reduces the pain associated with hyperacidity. So that's why, because it neutralizes the acids. Neutralize 50% of the gastric acid by raising the pH from 1.3 to 1.6. So this is the normal or the pH of the stomach. When it increases from 1.3 to 1.6 by these antacids, that means it is neutralizing 50% of the gastric acid. And if this pH goes from 1.3 to 2.3, that means that this antacid is neutralizing 90% of the gastric acid, because this pain and burning effect is associated with this acidity. So if we decrease the acidity, that means we are decreasing the pain associated with this hyperacidity. And drug-drug interactions with antacid, because all antacid may affect drug absorption. Most medications should be given 1 to 2 hours before or after giving the antacid. So because it can decreases the hyperacidity, and for some drugs this acidity is required, right? So that will this antacid will decreases the absorption of those drugs which requires acidic environment. Adverse effects: aluminum hydroxide. The adverse effects of aluminum hydroxide is constipation, while the magnesium hydroxide can cause diarrhea. So that's why it is usually taken in combination, so that will neutralize their each other's effect. Gastric hyposecretory agent. Now the drugs, this antacid that were only causing the neutralization of the acids, that were not affecting the secretion of this gastric acid. Now these drugs, H2 receptor blockers, muscarinic receptor blockers, and proton pump inhibitors, they causes the decrease in the acid production by the gastric parietal cells. So we will discuss this one by one. So H2 receptor blockers that we have discussed already, H2 receptors or histamine 2 receptors present on the gastric parietal cells. So these H2 receptor blockers are competitively and reversibly block H2 receptors on the parietal cells that reduces the gastric acid secretions. They include the cimetidine, ranitidine, famotidine. All these drugs mostly contain this tidine. So whenever it's with this tidine, or that means this is H2 receptor blocker. Cimetidine is the least potent, while famotidine is the most potent among all these three. If we go to the pharmacokinetics, it can have a good oral absorption. Duration is 4 to 12 hours. First pass metabolisms, it can be around 50%, but except nizatidine, which has 100% bioavailability. So it's almost 100. It has a less first pass metabolism, while others have almost 50% metabolism. So their bioavailability is almost 50%. Given before the meals, metabolized by the liver, excreted mainly in the urine, the normal cross placenta, and excreted in the milk. Right. So this is the general pharmacokinetics characteristics of these antihistamines or H2 receptor blockers. Pharmacological actions inhibit histamine-induced secretions, reduce basal and food-stimulated secretions, okay, reduce pepsin activity, and promote mucosal healing and decrease pain. So all these are associated with the decrease in the production of HCl. Uses a duodenal ulcer. For duodenal ulcer, it can be used for 6 to 8 weeks. For benign gastric ulcer, can be used for 8 to 12 weeks. Gastroesophageal reflux disease is also called GERD. It can be used for the management of Zollinger-Ellison syndrome. If that is gastrinoma. So increased amount of gastrin causes the increased release of histamines and also the HCl release. So in that case, we can use large doses of these antihistamine, and that will decrease the hyperacidity. Pre-anesthetic medications to prevent the aspiration pneumonitis and non-ulcer dyspepsia. Adverse effect of H2 receptor blockers is the GIT disturbance like nausea, vomiting, that is associated with the GIT, CNS, headache, dizziness, confusion in the elderly patients, and can lead to renal or hepatic dysfunctions. And cardiovascular, it can decreases the heart rate due to bradycardia and hypotension when given through a rapid IV route of administration. Intravenous, because it can causes the vasodilation and causes the decreases in the smooth muscle contraction or cardiac muscles, so that will lead to bradycardia and hypotension. The endocrine disturbance is mainly related to the cimetidine because it has these anti-androgenic actions, or it can affect the sex hormones in male and females. So that would lead to a gynecomastia and impotence in male, and galactorrhea in women. Galactorrhea is the abnormal release of breast milk in the woman. So it can also this is because this is effect is most commonly related with the cimetidine. Effect on the cytochrome P450, because it is cytochrome P450 inhibitors, and that's why it decreases metabolisms of oral anticoagulants like warfarines and the phenotines and benzodiazepines. These are the drugs, and these drugs have like low therapeutic index. So if you inhibit their metabolisms, then they can have their bioavailability is increased, and they can produce side or adverse effects. Okay, then proton pump inhibitors. Proton pump inhibitors, they are more potent because they are affecting the they are inhibiting the last stage in the production of HCl. So if you inhibit this pump, the messages or the stimulus that is coming either from the acetylcholine, histamine, or gastrin, all these stimulators are blocked. So that's why it has more potent action as compared to the H2 receptor blockers or the muscarinic receptor blockers. So the mode of action, it irreversibly inhibit the proton pump. This is irreversibly inhibiting this proton pump, that is hydrogen potassium ATPase, that is responsible for the final steps in the gastric acid secretions from the parietal cells. So this is the these are omeprazole, prozole. When you see this prozoles, mostly these are proton pump inhibitors. So omeprazoles, lansoprazole, lansoprazoles, pantoprazoles, all these are proton pump inhibitors. Pharmacokinetics, they are prodrug taken orally. So prodrug means they are inactive in their original form. They have to be converted to its active form by the biotransformation within the body. After given as enteric coated capsules, they are given as enteric coated capsules because they are degraded by the gastric environment, the gastric acids. They are rapidly absorbed from the intestines. They are inactivated if combined with H2 receptor blockers, have long duration of action like more than 12 to 24 hours, and that's why once daily dose is sufficient because it has a long duration of action. Pharmacokinetics, if you look into the pharmacokinetics, the bioavailability is reduced by the food, so that's why it has to be taken 1 hour before the meals. They are more potent than H2 receptor blockers. So if you look into the graph, this is the normal release of the acid release, right, in the from the stomach during the day or night. And this is graph. This shows the effect of the H2 receptor blocker. So it has short duration of actions and it can limitedly control the release of HCl because the other pathways like from the gastrin or from the sympathetic muscarinic pathway are active, right, and they are reversible. But this, if you look into the proton pump inhibitors, they are completely inhibiting the gastric acid secretions and for long duration of action, almost for 24 hours, because they are irreversible inhibitors. So dose reduction is required in severe liver failure. So in case of liver failure, because it is metabolized by the liver, so if the liver is not functioning, we have to reduce the dose of this proton pump inhibitors. Uses is Zollinger-Ellison syndrome. It's the first choice. We can also use H2 receptor blockers, but that for that purpose we have to use large doses of H2 receptor blockers. So this is the first choice for this Zollinger-Ellison syndrome or gastrinoma. Resistance severe peptic ulcer. For peptic ulcer which is resistant or severe, we can use it for 4 to 8 weeks. And reflex esophagitis, when the gastric contents come back into the esophagus because of the blockade or a blockade of the pyloric sphincter or any other reasons. Muscarinic receptor blockers, they are not commonly used, but they can decrease the HCl release. Pyrazines, it selectively block M1 receptors and inhibit the gastric acid secretions because of their relatively poor efficacy, side effects and risk of blood disorders. They are rarely used today. So we have better drugs like H2 receptor blockers and then more effective like proton pump inhibitors. So they are the main agents or drugs for the treatment of ulcer. Now, mucosal strengtheners. These are so we have discussed the drugs that were inhibiting the release of H cells. These are mucosal strengtheners. They provide strength to the mucosa or protection to the mucosal layer of the stomach. So what basically they do, they are basic aluminum salt of sucrose octasulfates. This is sucralfate, and what they do, they gives a sticky gel and adhere to the base of the ulcer. So if this is the ulcer, this sucralfate, it form a sticky gel, it binds or cover this ulcer area and provide a mechanical protection to this epithelial layers. So it is not altering the gastric acid or pepsin secretion, stimulate angiogenesis. So in order to heal or recover this in this epithelials, this has to be protected from the acid. So that's why it will stimulate the angiogenesis, the formation of these tissues again. Given in empty stomach, because it should have be given in empty stomach so that it can goes to the ulcer area and bind or form a sticky gel there. Not recommended for long-term therapy. Require an acidic environment for the activation, so acids given at the same times will reduce its efficacy. That's why, okay, it requires acidic environment. So anti-acid, if we are giving anti-acid at the same time, so anti-acid will decrease the acidity of the stomach, and this drug requires acidic environment to convert to its sticky gel formation. So that's why anti-acid should not be given before this drug. Sucralfate, the side effect, the most common side effect seen are constipations. Less commonly reported include flatulence, headache, or dry mouth. These are the common side effects associated, and mostly GIT, because it is not absorbed into the blood. So mostly the side effects are related to the GIT. It is used in the treatment of gastritis and stress ulcer. The another one, bismuth salt, it is almost the same like the sucralfate, so it has act in similar way to sucralfate. It also bound, it's also make a gel around the ulcer area, and it has strong affinity to mucosal glycoproteins, inhibit the pepsin activity but not the secretion, not inhibit or neutralize gastric acid, increases prostaglandin production. So it has added advantage of that, it can increase the prostaglandin production, and this prostaglandins further provide protection or decrease the acid secretion. Given in empty stomach, so it can also be given as an empty stomach. Okay, now the another mucosal defensor, prostaglandins analog. So we have discussed prostaglandins. It has basically multiple actions. One of the main action was that it can reduces the acid secretion from the proton pump. So that is one of the reasons that prostaglandin produces the gastric mucosa and appear to serve a protective role by inhibiting the acid secretion, and also it can also promote mucus and bicarbonate secretion. So this mucus and bicarbonate, mucus is also providing protection to the epithelial, and bicarbonate will decreases the acidity of the stomach. So it is providing multiple protection or multiple steps which can provide protection to the stomach. In addition, prostaglandins inhibit gastrin production and increases mucosal blood flow. So it can decreases the gastrin production, and it can, that's why it can increases the it has more kind of protective response to the stomach. Misoprostol is contraindicated in pregnancy. This is the misoprostol is this prostaglandin analog. So it should be not be given in pregnancy. It is contraindicated. Okay, now if the cause of ulcer is the H. pylori, then we can use the antibiotic drugs, which can eradicate this H. pylori as well. So H. pylori, it was discovered by Robin Warren in 1981. It's a gram-negative bacteria, and it breaks the urea into ammonia. That is its main indication. So this brain urea breath test, it is used for the diagnosis of this H. pylori, whether the patient has H. pylori or not. If the peptic ulcer is associated with the H. pylori, then we can use this proton pump inhibitor based triple therapy or quadruplicate therapy. We will discuss it in the next slide. And this therapy heals 90%. It has a 90% healing rate and prevent relapse. Then we can use proton pump inhibitor or H2 receptor antagonist, often continue for 4 to 6 weeks in order to ensure the healing. If the symptom is still there, right, or still there, then you can perform the urea breath test. This is the test which can use for the detection of H. pylori within the stomach. This is utilizing because we know that H. pylori is causing the production of urea, right, in the stomach, and that can be detected in the breath. So this is the kind of test which is used to diagnose or diagnose the presence of H. pylori within this stomach. So if this test is positive, then we have to give further course of this drug in order to eradicate the if this test is positive, then give further course of eradication using a different antibiotics. So we can change the antibiotics in order to eradicate this H. pylori. If the peptic ulcer is not associated with the H. pylori, then we can use other options, like usually if it is because of the using other drugs like NSAIDs, then we can withdraw that NSAIDs, or other factors like smoking or alcohols. These can also be associated with the peptic ulcer, so we have to discontinue that factors that is associated with this peptic ulcer. Symptoms of H. pylori are abdominal pain, feeling of fullness, indigestion, feeling hungry 1 to 3 hours after the eating, mild nausea, and pain start 2 or 3 hours after the meals or in the middle of the night, because at that time the stomach is empty. So whenever the stomach is empty, then this ulcer area is more exposed to HCl or pepsin. So that's why if we have food in the stomach, that will cover the ulcer area and will protect up to some extent that burning effect that is produced by the acids. So what are that triplicate and quadruplicate for therapy for the management or for the eradication of H. pylori? So the first line regimen for H. pylori eradication, it is recommended by the American College of Gastroenterology. Clarithromycin-based triple therapy. This is indicated for those patients who are not allergic to penicillins, or who have no previous exposure to macrolides. So we have discussed these antibiotics in the antibiotic section. So what these therapy includes: proton pump inhibitor, esomeprazole, clarithromycins, and azithromycin. So clarithromycins is a macrolides, and amoxicillins belongs to penicillin. So those patients who are not allergic to penicillins, who are not exposed previously to clarithromycin, so this is the first line therapy for those, and it can be continued for 10 to 14 days. However, if the patient is allergic to penicillin and who has previously exposed to macrolides, then we can use the second line therapy for this H. pylori eradication, and that includes the bismuth. This is called bismuth quadruple therapy. It includes the bismuth. Remember the mucosal strengthener. So bismuth subsalicylate, this is providing protection to the mucosal layer, metronidazoles, tetracyclines, and then we can add this ranitidine, which is H2 receptor blockers or proton pump inhibitors, esomeprazole. So this is combination of 4 different drugs. These two are the used for the ulcer. This is this is providing the protection to the ulcer area. This will decrease the acid secretions, and these two are the antibiotics for the eradication of H. pylori. Duration is also 10 to 14 days for this line of therapy. Diagnostic tests and procedures that we have. Routine tests are not useful for diagnosis of uncomplicated peptic ulcer disease such as hemoglobins or other. These tests are not applicable. So what we can use here is the breath test, urea breath test. It is used for the H. pylori. So that's all about the drug that can be used for the treatment of H. pylori. So we have discussed here the drugs that is affecting the HCl release, or that is affecting the HCl. So that drug includes the antacids that are aluminum hydroxide and magnesium hydroxide, which neutralize the acid. H2 receptor blockers, cimetidine, ranitidines, all these are H2 receptor blockers. And then we have proton pump inhibitor, omeprazoles. These prazoles are proton pump inhibitor, and they are more potent than H2 receptor blockers. We also have these antimuscarinic drugs, but with pyrazines, but it is less commonly used as compared to the H2 receptor blockers and proton pump inhibitors. Then we can have mucosal strengtheners, which provide protection to the mucosa. So they are mechanically causing the protection, sucralfate and misoprostol. So misoprostol is a prostaglandin agonist, right? So it is providing strengthening to the mucosa. So colloidal bismuth salt, they can also be used as for the protection of the mucosal layer. If the ulcer is associated with the H. pylori, then we can use this triple base therapy or quadruplicate therapy. For triple base therapy, we can use proton pump inhibitor along with clarithromycins or clarithromycins and amoxicillin, right? So those patients who are not allergic to penicillins and who have not taken that macrolide before, then this is the first line therapy for them. But if the patient is allergic to penicillin and who has taken macrolide before, then we can use this quadruplicate therapy, which include this omeprazoles or proton pump inhibitor. We can also use the H2 receptor blockers, bismuth salts, which will provide the bismuth subsalicylate, which will provide protection to the mucosal layer. And along with that, we can use these antibiotics, metronidazoles and tetracyclines for the eradication of H. pylori. So that's all about the drugs that are effective in the peptic ulcers. If you have any questions, please you can write to me or you can email me, and I'll be happy to answer. Thank you.